Psychiatric Residency Edition. I am Dr. O'Leary, a third-year psychiatry resident in the National Capital Region. I love making this podcast, but my love for it far outstrips my credentials and does not magically make more time for me to do it. I do this podcast really to help me understand more deeply the patients that wander into my office, what's causing their dysfunction, and what we can do together to improve their life, or at the very least, prevent things from getting worse. No one else that I know of endorses or approves my opinions. If they do, then they're as likely to be wrong as I am. My opinions are certainly not to be confused with those of, say, the National Capital Consortium Psychiatry Residency Program, the Department of Defense, the federal government, or the Society for the Preservation and Encouragement of Barbershop Quartets Singing in America, or anyone else for that matter. Today, I want to review one of the most frustrating diseases that a patient and their family might approach their psychiatrist with: Huntington's disease. Huntington's disease is a neurodegenerative disorder, which means that over the course of this disease, your neurons are going to die, or at the very least cease to function correctly, and it's going to get worse over time. It can have a long, insidious prodromal phase, or seem to develop much more rapidly. It's the death of neurons in the caudate nucleus and the putamen that results in these choreiform or dance-like movements that have earned the disease the moniker Huntington's Chorea. Chorea meaning like dance, like choreographer, and Huntington's after the first researcher to really fully characterize the phenotype of this disease. Choreiform movements are large amplitude movements, and they're really mostly noticeable in the limbs. But though those are the most conspicuous movements in the disease, they're also accompanied by other movement difficulties that can affect a person's ability to swallow, or to fix their gaze on an object, or to follow an object through space with their eyes. So over the course of the disease, motor problems can progress to more difficulty moving and even rigidity, like in Parkinson's disease. There are also likely personality changes, cognitive impairments, and behavioral disturbances that are associated with impaired emotional regulation. Huntington's disease is caused by a trinucleotide repeat of CAG on chromosome 4 in an exon that encodes a protein called Huntingtin, but in this case, the protein is malformed. The function of the protein in its normal state is actually not known, but if there are enough repeats, it will cause the protein, after it's made, to build up over time, resulting in neuronal death and dysfunction. Huntington's is considered an autosomal dominant disease because if it's inherited by one of the parents, it will be present in the offspring, regardless of their sex. However, its expression can vary, primarily based on the number of repeats in the region. So in general, having more than 26 repeats can result in the disease, and its penetrance, or the likelihood of being expressed as a disease, increases to about 100% when reaching around 39 repeats. So having more repeats generally means the disease will be present earlier in life and may even progress more rapidly. This is because repeats tend to accumulate and expand over generations. This early onset due to expanded repeats is a phenomenon known as anticipation. This genetic anticipation can also result in like a different kind of anticipation when like the children of affected parents anticipate developing the disease themselves, either because they had genetic testing to verify what variant they have, or they know there's a 50% chance that they carry it from their parent. If you take an image of a brain of someone with Huntington's, It will most likely show atrophy in that caudate and in the putamen, which are the regions that control or help us control motor behaviors. So in some cases, it can result in something they call boxcar ventricles, which is like a squaring and enlargement of the third ventricles due to loss of neurons in that area of the caudate and the putamen. But the cortex also can atrophy. An involvement of the cortex helps explain some of those neuropsychiatric components that people with Huntington's disease will experience. But imaging might also be within normal limits. Having normal imaging does not exclude the disease. Huntington's disease can result in many psychiatric symptoms, and these may start to occur during that prodromal stage that I talked about before the choreiform movements actually develop. So there's commonly sleep disturbances, apathy, executive dysfunction, memory impairment, personality changes, irritability and aggression, disinhibition and impulsivity, including hyper-sexuality in some cases, depression, mania, delusions, paranoia, and other psychiatric symptoms like obsessions and compulsions. But most prominently, there is a very high risk of suicide. Basic screening instruments and structured interviews can be useful for identifying symptoms of concern, and be sure to ask about the timeline of symptoms. So if you're treating someone who's already begun to experience motor symptoms, be sure to ask about prodromal psychiatric symptoms, or if anything had noticeably changed before. Also, because the brains of patients with Huntington's disease have some level of diffuse dysfunction throughout many different regions, the diagnostic criteria, as we apply them to the general population, should really be interpreted more in the context of the patient. So if they're having depressive symptoms, that can result in poor sleep, executive function, low motivation, psychomotor agitation, and suicidality. But in Huntington's disease, these symptoms could present for very different reasons than they're presenting in someone just plucked from the general population. Also, the symptoms may have more variable course, potentially spontaneously occurring and then remitting. So it's critically important whenever possible, when you have a patient with Huntington's disease, to include their spouse or their companion or a long-term caregiver of the patient when reporting and rating symptoms, because it's very common among individuals with Huntington's disease to have a decreased awareness of their own symptoms and poor insight. And the insight can become progressively poor or worse over time as the disease advances. This companion or spouse can help fill in those blanks that the patient is not even able to recognize, or provide a much more objective report of this is what the patient is doing, this is how they are acting. This is true even in the prodromal phase. Before motor onset, many of the prodromal psychiatric symptoms that a patient is experiencing might seem subtle or not really noticeable to the patient, but more obvious to their loved ones. Something else to always keep in mind when considering symptoms that are being experienced by someone with Huntington's disease is whether or not these symptoms are actually a side effect of medications that they're already on. For example, tetrabenazine or deutetrabenazine may be prescribed to help with hyperkinetic motor activity. These are human vesicular monoamine transporter type 2 inhibitors. And the result of that is a depletion of the monoamines serotonin, norepinephrine, and dopamine in a widespread way. Therefore, they can also worsen depressive symptoms and result in higher rates of suicidality. These drugs do exactly the opposite of what many of our antidepressants and psychostimulants are thought to be doing, which is to increase available serotonin, norepinephrine, or dopamine. So the use of these medications can result in low energy, low motivation, suicidal thoughts, akathisia or agitation, and anxiety. All of these are also not unexpected results of the disease itself. Although FDA approved tetrabenazine and deutetrabenazine are not really regularly used and often reserved for cases of severe uncontrolled motor function. A paper titled Clinical Management of Neuropsychiatric Symptoms of Huntington Disease, Expert-Based Consensus Guidelines on Agitation, Anxiety, Apathy, Psychosis, and Sleep Disorders. It was published in the Journal of Huntington's Disease in 2018. Reported the results of an expert committee's recommendations and relied heavily on responses to surveys sent out to clinicians. So the paper reported that there was a high level of consensus between these physicians, which is encouraging, but being a relatively rare and highly variable disease, Huntington's disease does not really lend itself well to having numerous clinical trials, and many trials that do exist are conducted by drug companies who are trying to find some support for possible pharmacologic agents. There are a number of case series in the literature. The previously mentioned paper asked experts to come up with priorities, and so they divided treatment strategies into really 5 domains, which included general treatment of psychiatric symptoms, apathy in particular, anxiety, agitation, and then sleep. So I'm going to highlight some of their recommendations here, but I've also included other readings at the end of the transcript for this podcast, which is located at psydactic.buzzsprout.com. Because the inheritance of Huntington's disease CAG repeats results in genetic anticipation, it can present early in life. Rarely in adolescence or childhood, but more commonly like around middle adulthood. This means that the patient has also had time to develop other comorbid medical conditions such as like diabetes, cardiovascular disease, or other brain or bodily injuries, or even other psychiatric disorders. So at the time that they present with a life story. The patient also is in a socioeconomic and cultural context that has folded into it many other challenges, some strengths, and other determinants of health. So be sure to have a really good grasp on what the patient's already bringing to the table, including the resources they have available and challenges that they're probably going to be facing in the future. So as a treating physician, you'll be responsible for educating the patient and their family on what to expect and how to cope with it. So be prepared for an alignment with them that goes beyond just mere office visits for medication refills. One of the prominent challenges that families and patients will face is agitation. If you listened to my podcast in the past, you might remember that I've complained a lot about the use of the word agitation in medicine. It's frequently poorly defined, and its definition seems really highly contextual. When families come to us to report agitation, it might look something like the inability to sit still, resistance to requests, talking too much, not listening, yelling and screaming, throwing a fit, insulting others, physically attacking or resisting interventions by others. And so that's a lot of very different things, and it's not even close to a comprehensive list of what might be called agitation. But one thing that does define agitation is that it's something that makes itself obvious in the moment. It's obviously a problem. Unlike, say, apathy, that might take days or weeks to really identify as a problem. Why aren't they doing anything? It constitutes really a broad range of actions that are not socially acceptable at the time that they occur. So, similar to agitation in delirious patients, it's really important to make sure that the environment that they're in is not exacerbating the problem. First, educate families to take calming measures and use distraction or reorientation to help prevent worsening of whatever is happening. It may be that the family member needs to calm and reorient themselves first before they attempt to do that with their loved one, because these situations can often be overwhelming. Providing like familiar, trusted voices or calming stimuli like their favorite music might help. It might be best actually to not engage at all, just to provide a safe space where the patient can calm down. And definitely remove any noxious stimuli that might be overwhelming the patient. Check for deficits in their senses, such as problems with vision or hearing that might be making it more difficult for them to orient themselves. Patients with Huntington's disease often also experience hallucinations or delusions, and these need to be identified so that they can be dealt with as sources of distress. Also, assess for pain and treat it appropriately. Now, someone who's agitated may not perceive in the moment the pain that's actually disturbing them or really be able to communicate it. So, a trial of acetaminophen in a patient with good liver function, or some NSAIDs like ibuprofen in those with good renal function, can be safe just to try, and often will be helpful. For acute agitation that doesn't respond to all of these interventions, like reorientation, distraction, calming, then you can add on low-dose antipsychotics. Benzodiazepines can also be helpful in the acute phase, but really care should be taken because benzos might cause this paradoxical agitation. And as I'm going to repeat later, they should not be used for chronic treatment in Huntington's disease unless everything else has failed. Antipsychotics, on the other hand, may be helpful not only for agitation, but also as chronic treatment to reduce motor symptoms, to reduce, say, delusions or paranoia patients might be experiencing. If agitation is frequent, then there might also be underlying irritability or obsessions or depression that needs to be treated with antidepressants like SSRIs, SNRIs, or a tricyclic like clomipramine, or even an anticonvulsant, which psychiatrists often refer to as mood stabilizers. Dr. DePietro, I can hear you groaning as I use that term. Clinicians often focus on agitation because really it's an obvious symptom where it makes itself obvious and can result from other problems that the patient with Huntington's disease is experiencing. But other symptoms to be aware of are apathy and depression, intense anxiety, psychosis, and chronic sleep disturbances. Let's look at apathy and depression. Apathy can look like an anhedonic depression, and in different surveys has been present in 1/4 to 3/4 of patients with Huntington's disease. It tends to become more frequent after motor symptoms are manifested, especially because motor symptoms tend to progress from hyperkinetic and involuntary movements to more bradykinesia and rigidity later. Apathy can be seen as a lack of emotion or motivation in many different areas. So anhedonia is specifically the inability to experience pleasure. You may see abulia, which describes the inability to make decisions or to act decisively. And then there's alexithymia, which may be another component of this apathy, and it literally means having no words for someone's feelings or the inability to put one's emotions into words. Apathy in Huntington's disease is not necessarily the same thing as depressive symptoms that you've seen in other patients. Apathy might result in a patient apparently lacking the motivation to do much of anything, even to eat. And to be true apathy, the symptoms need to be distinct from the patient's inability to eat because of motor dysfunction. Catatonia can also result, and there are case studies that have demonstrated that ECT is effective in Huntington's disease as well. In one review, 18 out of 19 Huntington's disease patients experienced improvements of their catatonia, psychosis, or depression, and their overall functioning when they received ECT. But that 1 out of 19, in particular, experienced a significant worsening of their motor symptoms. For a more thorough review of ECT or electroconvulsive therapy, look back to my first 3 episodes of this podcast. We don't know why apathy develops in Huntington's disease, but it can develop early. The most prominent early changes on imaging in Huntington's disease are in the striatum, so it's kind of natural to suspect this area of the brain. One of our main emotional processing networks involves what has been called the limbic loop. It's the ventral striatum, receiving projections from the anterior cingulate, the orbitofrontal cortex, and the dorsolateral and ventromedial prefrontal cortex. These regions are involved in the experience of emotion and of motivation, but also, when dysfunctioning, can result in obsessions and compulsions. There's not enough studies to be able to draw any definitive conclusions about what kind of network dysfunction is causing depressive symptoms or apathy or emotional dysregulation in Huntington's disease. And it could be many different things depending on the patient. There is often classical features, low mood, poor appetite, low energy, poor concentration, difficulty thinking or making decisions, and possibly even psychomotor agitation or retardation, along with feelings of guilt and worthlessness, and especially suicidal ideation. Patients with Huntington's disease are at least 6 times as likely to attempt suicide as the general population, and one review I read reported a risk of 12 times higher. The frequent screening for depression and apathy is important, and SSRIs are the first line for both. I've not been able to find much evidence that would help me to decide which SSRI is the most effective. Fluoxetine has been called an activating antidepressant, but I wouldn't trust that general responses like these expected in the average person walking into your office would be helpful in predicting responses in patients with Huntington's disease. All I can say is that I would avoid SSRIs that are more anticholinergic, like paroxetine at the onset, unless you have really another good reason for this. Don't be shy switching to a different SSRI if the first was ineffective. If you started, say, escitalopram and it didn't work or had intolerable side effects, then it'd be reasonable just to switch to sertraline before abandoning the SSRIs altogether. If you have comorbid sleep problems, the expert opinions in the paper I mentioned earlier seem to favor mirtazapine or clomipramine. As a reminder, don't be afraid to stop or taper a drug that's not working and just try something else. It might be tempting to start a psychostimulant in Huntington's disease patients like methylphenidate, atomoxetine, modafinil, amantadine, or bromocriptine to treat the apathy. These all have different mechanisms of action and may be helpful adjunctively or at low doses. However, evidence for their effectiveness in depression in Huntington's disease has not really been studied in randomized controlled trials. And they do present a risk of worsening other psychiatric symptoms. So really care should be taken to have close follow-up if you're going to choose to use one of these. When first seeing a patient with Huntington's disease, you might notice that the neurologist has already started them on, say, amantadine because it can help treat some of the motor symptoms and maybe improving cognitive symptoms as well. Not surprisingly, anxiety often accompanies depression in Huntington's disease. The first-line treatments for anxiety overlap with your treatments for depression, so you don't have to worry about choosing to treat one or the other. However, it can be really tempting to give benzodiazepines, which are a double-edged sword. Chronic treatments with benzos is associated with worse outcomes in Huntington's disease, so really be judicious with their use. Psychotic and obsessional symptoms can result from Huntington's disease as well, and they can be early or late. So increasing degeneration of the striatum and that orbitofrontal circuit probably contributes to the development of some of those socially inappropriate behaviors. The damage to the corticostriatal circuits also likely contributes to obsessions and compulsions that they experience. However, there's really a lot more malfunctioning in the brain of an individual with Huntington's disease than someone whose just primary complaint is obsessions and compulsions. These may respond to SSRIs, but severe obsessions or psychotic symptoms require the use of antipsychotics. If there's a large obsessional component and you have difficulty falling asleep, you can try like tricyclic antidepressant clomipramine, which is highly sedating and also demonstrated efficacy for these obsessions. You can choose antipsychotics because they can also reduce the motor symptoms of Huntington's disease by slowing down traffic in the striatum altogether. Atypicals are preferred, but there's really little guidance on which to choose. So side effects should be considered and might be actually helpful. If sleep is another huge issue for your patient, sedating antipsychotics like quetiapine may be helpful. Also, don't push the doses up high quickly. Monitor for responses at low doses and maintain these if there's a good response. If psychosis does not respond to two different antipsychotics, then don't forget that you can reach for clozapine. We often wait too long to start this drug because of the need to monitor patients for like neutropenia, myocarditis, or severe constipation or ileus, all of which can be fatal. But it really remains the most effective antipsychotic there is. So if you can monitor your patient, then use it. Now, after starting an antipsychotic, you have to be aware of side effects, which can be really hard to distinguish from symptoms of the disease itself. So Huntington's disease is known for chorea, or large amplitude involuntary muscle contractions, but dystonias and rigidity can also be present, especially later in the disease. Akathisia or restlessness can also be either medication-induced or just part of that degenerative process. When adjusting medications in Huntington's disease, it's reasonable to slowly adjust doses up and then slowly down again to see if there's improvement or worsening of symptoms. Someone with Huntington's disease may have been on an antipsychotic for a very long time in order to better control their involuntary movements, and this might be masking or treating brain network dysfunction that would otherwise have resulted in some sort of psychosis. So be aware that reducing an antipsychotic might also unmask obsessions, delusions, or hallucinations. I want to pause here and reinforce that care should be taken to avoid unnecessary polypharmacy in these patients, especially if you're trying to treat the side effects of one medication with another medication, and this can really confound the picture even more. Initially, instead of adding a med, try reducing one. It may take some skill to develop a good therapeutic alliance with Huntington's disease patients and their families, so that they know that they have an advocate in you and that you will help them get through this. Today, I reviewed Huntington's disease because I expect to have patients come into my office in the future with this illness. I'm not an expert in Huntington's disease, and my clinical experience leaves much to be desired. I just want to be prepared, and I hope this review will help residents and other psychiatrists early in their practice to at least have a good place to start if a patient with Huntington's disease arrives in their care. Thank you for listening. I am Dr. O, and this has been an episode of Psychiatric Residency Edition.